neighborhood now, but six shooters, bunch of robberies.
We were discussing that this past weekend. It's just getting out of hand. I mean, all over the United States, I mean, man, kids like that running around you guys.
Yeah. Well, roughly about 31, just about 31 years now, I joined Chandler, which is an undercover agency. We give training and all that
Yeah,
stuff,
I
and
see it.
insure and all that.
Right.
And then I'm carrying $2.5 million worth of insurance if I ever need it. But I carry all that. And we have to go to different situations, like when they had riots, they called us, and then we went in undercover to see if we could find out what the issues was.
So you give these classes, these seminars on people apply for it?
Yep. We were doing it at Poland. Now, quite a few of the seminars that I'm going to that I do basically are Duluth, Sandstone, Eastland, and Pinehurst.
My grandson. I don't want one. I couldn't shoot anybody anyway. No, really. Somebody would have to shoot at me before I could shoot back.
That's the main idea. You know, it's really sad though. A lot of these companies, you always see, I just happened to be over at Capway the other day, and I seen a thing up there, we'll teach you the ins and outs and all this stuff. You know what? I checked in on this stuff. They don't insure. They don't actually give you all the rules and regulations of every state. They tell you what states are good.
Well, how many states now? How many states does that have?
Right now, it's only valid for 17. That's all, including Florida. But you got other states such as Texas, which would be legal anyway in Texas, because that's a constitutional state. You got Arizona, constitutional state. What we're concerned about, looking at and all that is California, look at the Constitution. That is not close. So I don't like constitutional.
What's the mean? Does that mean you don't even need a permit?
Anybody and everybody. When we give you your training, 8-hour class, then what we do is we do a search warrant. Please. That'd be great. We do a search for it.
Yeah, this is, I don't remember your name.
Gary.
Janitor here.
Janitor, maintenance, cleaning.
Yeah, does everything.
My wife is starting to help in the office.
Was she? John, do you vacuum in here?
Yep.
You know, yeah.
You know, Lydia picked me up, I've been trying to figure out how to do those.
Good morning. We are going to go ahead and get started. I think we're also on live stream, so welcome if we have anyone joining us there. This is our final in our series, our end of life series, and today will be about healthcare directives, and we have a guest speaker who I'll let him introduce himself here in just a moment, Roland Brummer, who generously made the drive to be with us today in person. I want to just do a couple pitches. I wanted to let you know we are doing mental health first aid. It is a basic class about recognizing signs and symptoms that might be in people that might be having a mental health challenge, including ourselves or our loved ones. And then it teaches you how to respond and how's a helpful way to respond. So if you're interested, we're doing that May 3rd and 10th each day for 4 hours with a lunch break in the middle. There's a sign up in the office if you're interested, and there is limited seating, so we encourage you to sign up. What else am I? There is a $10 charge. We are ordering $30 worth of supplies for each person, and so we just want to make sure that those that are registering will be in attendance with us. So we're asking for $10 from each participant. I want to acknowledge and recognize the Adult Education Committee and Mary for all the work, and Pastor James for all the work that pulling all of these series off throughout this winter. It's been great to just see people coming and hearing positive comments about that they were helpful sessions for people. So I'm going to turn it over to Roland, and he will walk us through the rest of the morning. Thank you.
It's good to be here. Thank you. Thank you for having me. I very appreciate your inviting me. Thank you so much. And thank you, Pastor, for setting this up. I need to put my mic up. Here we go. Can you hear me well? Are we okay on live stream for hearing me? I think so. Okay. We're good. Can I run around and you don't have to keep me on any particular place, can I? I can move? Great. I can't talk without moving. Good. My name is Roland Brummer. I am a retired RN. I worked at St. Cloud Hospital. I live in St. Cloud right now. I worked at St. Cloud Hospital for 28 years in the cancer unit at St. Cloud Hospital. So, and I was just telling, I can't remember your first Darlene, who's also a registered nurse. I told her I worked for 30 years in healthcare and I never wrote a healthcare directive. And so I got retired and I said, you know, I should do this. And I did it. And my wife went with me and we wrote our healthcare directives, which was great. So I'm here today to kind of help you put together a healthcare directive. I don't know if you're going to be able to finish everything today because a lot of times when I help people work with healthcare directives, there's things you want to go home and talk about with your healthcare agent, the person that you're going to have making decisions for you if you can't make decisions for yourself. But we're going to go through the whole form. The Minnesota form is called Honoring Choices, and I think you all have that form with you. Is that correct? And hopefully you all got some scratch paper too that you can take notes from for it. I'll start by telling you the value of writing healthcare directives. In my work as a cancer nurse, what I saw when people hadn't talked to their friends or their relatives or their loved ones about what they wanted done at the end of their life, or if they had serious illness and couldn't speak for themselves, what I saw is that it was very, very difficult for your loved ones to say no to any treatment that was offered. Because what happens if you say no, then for the rest of your life you think about, I wonder what would have happened if we would have done this for mom or dad or whomever. And so a lot of times in my work, I can tell you clearly, for every time that I questioned if a patient was being undertreated at the end of life for cancer, I questioned 50 times if a patient was being overtreated at the end of life. And by writing your healthcare directives, you can take that burden of decision-making, partially at least, away from your healthcare agent and your loved ones, so they don't have to take responsibility for it and wonder inside. They can, when they make decisions for you and speak for you, they've got something, they've either talked to you or they have a form in their hand that says, this is what mom or dad or whomever, my loved one, my spouse wants to have done. And they don't have to question themselves. So you take that burden of responsibility away. It's not easy conversations to have. I will assure you it's not easy. About a year and a half ago, in the middle of the pandemic, I developed severe coronary artery disease, and I needed open heart surgery. And before the open heart surgery, my doctor said to me, there's about a 1 or 2% chance you might have a stroke as we're in the middle of open heart surgery. At that point, I said, you know, I need to talk to my wife. And fortunately, she was able to visit me in the middle of the pandemic because the pandemic wasn't too bad in July of 2020 when I had my surgery. So she was there, and I could tell her, if this happens, if I can't swallow and I need a feeding tube to feed me, it's okay to do it for a while, but don't do it forever. Don't keep on doing it forever. If I don't know you and I don't know what's going on, don't try to extend my life too long. I just don't want it. I don't want it. If I can't get out of bed and I'm stuck in bed and I can't get around, I don't want to be stuck in bed forever a day, you know, with the feeding tube hooked up to me, not knowing who I am. I don't want that kind of life. But try things for a while, and if they don't work, shut them down. And I mean, when you think about strokes, you don't know. Strokes can affect so many different parts. in a healthcare directive, you never can know exactly what might happen at the end of your life and what kind of decisions your loved ones might be needing to make for you. But it's so important to talk about it because otherwise the burden of decision making is on that person. And if they don't know what you want, they're probably going to say, let's do everything we can to see what we can do because I don't want to take responsibility for mom or dad or my loved one to die without doing everything we can. And a lot of us don't want everything done. We don't want to be laying there it's kind of as a vegetable going on for a long time. So with that, I want to get to know you guys. So I'm going to ask you to tell me your name, and I'm going to tell me why you came today. And you want to start here?
Bev Swenson.
Bev? Okay, Bev. Why are you here today?
I just want to know more about all this.
Okay, great. Well, good. Good to have you.
I'm Janet, and I came so that I could get my paperwork in order, so I could take that burden off my children
Good.
when the time comes.
Wonderful. Bev, is that your name?
Jan.
Jan. Bev. Jan. Okay.
I'm Wallace Swenson. I'm Bev's husband. I don't know why she didn't say it with me.
We'll talk about that later, huh?
I want to look at it.
Uh-oh. So, well, good.
Anyway, I'm just curious. We went to one of these seminars a few years back over in Church
Uh-huh.
in Aiken, and it kind of refreshed me.
Great. Great. Good.
My name is Gary.
Okay.
Just kind of a refreshment on what's going on, because we're still calling up our main directives and all that stuff.
Okay. Great. Good.
Darlene, I'm here, I've helped people do directives before, and I have one, but there may be something new, something I want to change in it.
Okay. Great. Thank you.
I'm Joanne, I have one also, but I want to listen and see if there's something that has changed or I don't know.
Okay, that you want to put different on it. Okay.
And I'm Mary, and I also have a healthcare directive, but I want to see if this is any more in-depth, and if there's,
Okay.
I looked at mine, and there's things that need to be changed.
Okay. Great. Great.
I'm Dave, and I came to know about healthcare directive. I do not have one.
Okay. Good.
I'm Cleo, and I also have one, but I just wasn't sure about it.
Okay. Good. Oh. It's good to check those over because as our condition changes, as we age, and as health changes, things change. Yeah. What to do? Okay. Good.
I'm Pat, and I have a healthcare directive, and I know that there's.
You are in one, aren't you?
And so it's kind of like this interesting chapter ones and the questions that they ask.
Good. Good.
I'm Patty, and I just came, because I don't have one. I know I should have. And my husband had one, and he passed away during COVID. So I do know how important these are towards, and we never know. So
Sure.
I just need to know.
My condolences on your loss. Sorry.
Julian, I have a healthcare directive, but it's always good to make sure it's updated.
I'm Pastor James. I don't have a healthcare directive, but I also work here, so.
Oh, okay. So you're taking care of the streaming. Is there people online right now, Pastor?
Not too many. Not
Okay.
really any right now.
Well, welcome to the.
We do record it so people can.
Okay, great. If there's people on that have questions, if you can let me know in any way, okay? Yes, Mary.
I'm Mary, I have a healthcare directive, and I have been fortunate that I have had one accessible to me when I needed to use them with one. So
Wonderful.
they're important.
I'm Judy,
Huh?
and I don't have one, and I want to learn about it. Talk to the kids. Lost my husband in 2013. And help with.
Did that make a difference? Was it hard? It's hard to talk about these things with your loved ones, but it's even harder not to have talked about these things with your loved ones. Wonderful. And you've got a beautiful dog.
Thank you.
What a well-trained dog. Hi, buddy.
Oh, she is.
What's her name or his name?
Daisy.
Daisy? Hi, Daisy.
She was named Daisy Beth.
Okay. After the church? Okay. Hi, Daisy.
Because she was a stray around.
Oh, okay, great. Wonderful. Thank you. And why are you here, Daisy? Oh, I'm scared. Daisy? I scared you. I'm sorry.
No, here, go say hi. Go say hi.
Want to say hi?
Go say hi.
Want to shake hands? No? Okay. Okay. Here you are. Okay. Okay.
I'm Dean, and Cheryl and I have been meeting to fill one of these out for years, and thought this would be what it takes to put us over the top.
Great.
I'm Cheryl, and I'm tired of everybody asking, do you guys help? I'm the advocate.
I can help you. Oh, great.
Hi, Gene, and as a healthcare directive, I'm updating it since the passing of my wife, because I know how hard it is to do, even though you have to direct. But you do what they ask. It's for them, not for you.
That's right. That's right. And it's also for you, though. It's also for you that the right things get done. The things that you want to done and not done, it's done properly for you. And yeah, it's good. Okay, let's talk about our healthcare directive. Let's go over this form, and we'll kind of go through it step by step by step, and we'll talk about things. The form that you have and that I have here is Honoring Choices Minnesota. To the best of my knowledge, this form is accepted in any state of the United States. It's acceptable in all different states. Some forms, I think, aren't acceptable in all states, but I've been told that this form can be accepted in any state. So if you go south for the winter or whatever, this form would be accepted in another state. And we're just going to go through this part by part. You know, I even though I worked in healthcare for almost 30 years, I did not feel comfortable doing a healthcare directive without some help, just because these decisions are so important, and I wanted to make sure I understood what's on the form. And I'm so glad you're here. And if you have questions as we go through this form, please ask questions. That's what I'm here for, is to help you understand what's on the form. First of all, the introduction says, I've completed this healthcare directive with much thought. This document gives my treatment choices and preferences and/or appoints a healthcare agent to speak for me if I cannot communicate or make my own healthcare decisions. My healthcare agent, if named, is able to make medical decisions for me, including the decision to refuse treatments that I do not want. And then there's a little note here. It says, this document does not apply to intrusive mental health treatments, defined as electroconvulsive therapy, also called ECT, or neuroleptic medications. So it's a different world when you're dealing with people with severe mental illness. And so this document is not a really good document for people with severe mental illness. So it doesn't affect some of these treatments that would or would not be used for mentally ill people. And the first thing you do is you fill out your name, your date of birth, your address, your telephone numbers. All those things are important. What I would do for name, I would write your full name on that, write your full legal name on that, so that people know, so that when they read the document, they know it's your document. It's written in your name. And do you want me to let you fill out this, or do you want to just take notes as we go and then do it that way?
Yeah.
Just take notes? You want?
Yeah.
Okay. We'll go through the whole document, and when you have any questions, ask a question. It's got a little box here. It says, my initials here indicate a professional medical interpreter. Help me complete this document. I am not a professional medical interpreter. I am a volunteer. So I am here as one of you. So do not put your initials in that box. And then part one, which in many ways is possibly the most important part of this document, but certainly, and if not, certainly a very important part of the document, is your healthcare agent. And, okay, I forgot one statement. Just above your name it says, any advance directive document created before this is no longer legal or valid. When you sign and have this witnessed, any former document, those of you that have a document, if you write a new one, be sure to destroy the old ones. You don't want those just laying around. And if you've given them to your person who's your healthcare agent, make sure the old ones get destroyed, because you don't want to have 2 or 3 things and then trying to figure out which one was the newest. So whenever you fill out a new one and make it legal by having it signed and witnessed, be sure you get rid of any old ones that you've written before. you that I've written it before. When you fill out a new one, don't keep that old one unless you want to put it in the archive somewhere, but put it far away in the archive somewhere so people won't find it anywhere there. Now, your healthcare agent, part 1. If I cannot communicate my wishes and healthcare decisions due to illness or injury, or if my healthcare team determines I cannot make my own healthcare decisions, I choose the following person to communicate my wishes and make my healthcare decisions. My healthcare agent must follow my healthcare instructions in this document, follow any other healthcare instructions I have given to him or her, and make decisions in my best interest. So this is a legal document. Your healthcare agent is required to follow your wishes and what you write into this document. The thing is, though, you can never know the exact circumstances of what's going to be happening. And so when you write this document, there's going to be extenuating circumstances, and he or she is going to have to interpret your wishes a bit. So the more clearly you can make your wishes, the better you are. Yes?
Okay, on my former, on my other health directive, I need both of my children.
Yes.
So, because, and I know it's here, it says primary and alternate.
Yes.
The reason I did that is because I did not want a conflict between the two.
Okay.
So, using this one, you cross off alternate.
Yes, you can cross off and say second primary. Second primary. If you want them both to be primary, and you could have 5 primaries if you want 5, and you can fill out. You get put an extra piece of paper on here and fill it out. You can have as many primaries as you want. It gets a little complicated when you got more than one primary, because then they need to agree, and they need to agree as to how to interpret your wishes. So if you're going to put 2 primaries on there, you probably want to make sure you talk clearly to them as to why you chose them, and make sure that they and show them the document carefully and say, can you follow this document, and you all both understand this pretty much in the same way. And again, you're never going to be able to put down every possible circumstance that could happen to you, but make sure that they understand what it's about. For those of you that have 8 children, if you decide that you want one for your primary healthcare agent or whatever, you don't have to have children. It isn't like you have to have your next of kin, or you don't have to have your spouse as the healthcare agent. Whoever you think can do the best to fulfill your wishes on this document is the person you put down there. But if you have a whole bunch of children, if you have 6 or 8 children, you've decided that I want so and so to be, because this person knows me the best and this person lives closest, and so I want that person to be it. It's a really good idea then to talk to the rest of your children and say, I chose Jim or I chose Mary because they're closest to me. Or, they've got twins. What are we going to do with that? Okay. And I guess the most important thing is that you look at yourself and think about it and say, do I trust both of them? Do I trust one of them more than the other? Yeah, who do you trust? Who do you trust to be able to fulfill your wishes? So it might be that you'd want the one in Minnesota because they're closer, more available. And if you chose that, you could tell the other twin, you're in England, I trust your judgment. I think you do the best you can, and you can communicate with my other one, but I chose this one because this person's closer and easier to contact. But you just want to make sure that your children know why. The biggest problems I've seen with healthcare directives is when the person who lives closest to you and maybe knows your wishes the best says, yeah, this is what mom wants, and we've talked about it a lot, and I'm appointed as a primary agent. And then someone comes from out of state and says, we might be able to do more for mom. Maybe we should do more for mom or for dad. And that's where those are the really difficult situations, when healthcare providers are hearing 2 different messages from 2 different people, and if they know who the primary one is, then that's the one they need to listen to. But still, it's just not fun when you've got family members in conflict at the end of life. And so the better you can do to explain to your family members or whoever you choose to be your healthcare agent why you chose them, you're going to be making just a lot better at the end of your life for them and for you as well. Does that make sense? Yeah.
I I just had a situation where my twin brother and his wife just made their healthcare directive, and we had a discussion about who was gonna be their primary, and being twins, I assumed it was me, and it isn't, and it was a good discussion to have early, that they told me they chose so-and-so of their generation and so-and-so of the younger generation, and why, and, so I think.
Yeah,
you know,
so they're not trying, most of the time, people aren't trying to snub somebody, you know.
No.
They're trying, they're just saying, this is a person that I think would do the best job in this.
And I think it's important to relay to your family and everybody else who you have chosen in advance, so they're not at each other at the last minute going.
Absolutely, because those situations are not good. When that kind of conflict is happening at the end of life, no one's real happy. It's a mess. Okay, other questions about this in particular? So the primary one would, if, for example, you were in a car accident, you were in the emergency room, you couldn't speak for yourself, the primary agent is the one that they're going to call first and say, this is what's happening, what do you want done? If there's questions of what should be done. If they can't get a hold of the primary agent isn't answering their phone, they would then call the alternate healthcare agent and ask, what do you want done for this person you are on? And it's a horrible phone call when the primary agent is called and so-and-so is in the hospital and can't speak for themselves, and you are the primary agent on the healthcare directive, and what should we do? And they say, I didn't know I was a primary agent on that healthcare directive. That's a horrible phone call. That's a horrible thing because that person is just, now what do I do? Kind of stuff. So be sure to let them know. If you don't know the address of your healthcare agents, the address is not half as important as the telephone number. In an emergency situation, it's the telephone number that needs to be on there. And if on this document, if nothing changes but your telephone number of your healthcare agents, cross off the old one, put a new one on there, make sure it's up to date because that's very, very significant. But you probably don't have to write out a new healthcare directive in order to change a telephone number. Just cross it off, put your initials and say, this is the new telephone number. Make sense? Other questions about that? Okay, we're going to go to page 2. And it's just got a few things here. It says, I understand my healthcare agent, primary or alternate, cannot be a healthcare provider or employee of a healthcare provider give me direct care unless I'm related by blood or marriage or I give a clear reason why I want that person to serve as my agent. You don't want your doctor to be your primary healthcare agent unless your doctor is your son, or whomever. But it's a conflict of interest because they're getting paid for your care. And so by giving you more care, they might receive more pay, and it can be an appearance of conflict, if not a conflict for that. But if you have relatives who are healthcare providers, they're great healthcare agents, great people, because they understand things a little bit better because they studied it, so they understand maybe a little better what CPR might be or what different treatments might be. Okay. Any questions about that? And then these are the powers of your healthcare agent, and you can restrict any of these powers, but this is what's given if you don't put any limits on it. First of all, they can agree to, refuse, or cancel decisions about your healthcare, tests, medications, surgery, tube feedings, any other treatments. They interpret the instructions in this document based on his or her understanding of your wishes, values, and beliefs. They can review and release your medical records. So when they're on this document, at this point, you can still speak for yourself. They really don't have to be looking at your records. But as soon as you can't speak for yourself, they have complete authority to look at all your medical records, so they can see all your medical records. Arrange for your healthcare treatment in Minnesota or other state or location. Decide which healthcare providers or organizations provide your healthcare. Make decisions about organ and tissue donation and autopsy according to your instructions. We'll talk about that later on in the document. If there's anything you don't want them to do, you can put a limit on that. But if you say, well, I don't want them to see my medical record, well, that's probably going to be a problem because they need to be able to know that in order to be able to make good decisions for you. So, but if you want to put any limits on it, you can just write it in the comments level here. In any of these parts, if you want to write in more than what there's room for, you put see additional page, and you can attach a page to it. I've had people have healthcare directives that had about 15 pages of attached records. Some people are very thorough, and they try to imagine every situation, which is difficult to do. But you can write down as much as you need to. And then you can give additional powers to your healthcare agent. They can make decisions about the care of my body after death. If you've been in touch with a funeral home and made pre-arrangements for your funeral, then don't check that box. If you want them to be deciding what to do with your body, whether you are cremated or where you're buried or what kind of services to have, you can put your initials in that box. Continue as your healthcare agent even if your marriage or domestic partnership is legally ended or has been ended. If you put your spouse as your healthcare agent on this document and you were to get divorced from your spouse, and I'm not saying that any of you are going to do that, but if you would, your spouse would no longer be your healthcare agent unless you made a specific statement on a healthcare directive saying, I still want them, your ex-spouse, I still want my ex-spouse to be my healthcare agent. So otherwise, if you get a divorce and you've got your spouse on there, the assumption is that you don't want them to be it anymore unless you make a statement that you do want them. Make healthcare decisions for me even if I'm able to decide or speak for myself if I so choose. And that's a strange one. I don't think anybody really ever has to do that, but what happens sometimes is when you're really sick in the hospital and the doctor comes and says to you, you know, we could do this or this right now. And you've got your mind and you know what's going on, and you just say, I am just too tired to think about making a decision. Why don't you ask my healthcare agent, because I don't want to make it. I'm just too tired. I'm too sick. I don't want to think about this. And you can do that. But the other thing is about that situation is whenever you still have your mind and are able to make decisions for yourself, whatever you say completely overrides anything that's on this document. So if you say, I don't want to make my decisions for myself right now, ask so-and-so, it overrides anything. If it's a different person than your healthcare agent in this document, if you're of clear mind, it totally overrides this document. So when you're of clear mind, you can change anything. That's what goes, and this document has no force until you're not of clear mind. Yes?
And I know this happened during COVID, but I don't quite know how to word the question, but when does the okay, I have heart attack,
Uh-huh.
and I'm no longer able to speak, and I'm rushed to the hospital. So when does the doctor's wishes during that time versus the health directive? In other words, the doctor's gonna try to save my life, right?
Perhaps. Perhaps.
Yeah, okay. And the reason I'm asking is because, for example, my brother had a serious heart attack, was not able to talk to himself, it was during COVID. And my brother almost died on the table, but the doctors did everything possible to save him. Now, would they check the health directive and say, no, we're not gonna resuscitate, we're not gonna use the paddles, we're not.
If the healthcare directive says no CPR, no resuscitation, the doctor would be obligated to do that. Now, there's some exceptions here, or some things here. This is when, if, for example, if you're, let's say, I don't know if your spouse is alive or not. No, okay. If you're living with someone and they collapse in your house, and you say, wow, we got to get help. You call 911. The EMTs come to your house. Unless the EMTs have specific, obvious instructions, usually a POLST form, which is a physician order for life-sustaining treatment, that they can see right when they walk in the house, they're going to do CPR. They're going to do resuscitation because that's what EMTs do. And unless you can give them immediate proof that this is definitely not wanted and doctors agree with this, etc. So POLST, the physician order of life-sustaining treatment, they are going to do resuscitation. And that can get really ugly.
I guess I'll just chime in a little bit. As a first responder, I've been to houses where they had DNR, do not resuscitate, on their refrigerators. resuscitated. And even then, it becomes challenging. I mean, there was no question about what they wanted, but it's hard for people to
Yes,
not.
because as a first responder, you kind of have an obligation. You know, that's what you're there for, is to
And if
save
the
the life.
family is telling you, like sometimes.
And if
we
there's
have-
any question, then it's forget it. We're going, oh, I'm sorry. What did I do? But yeah, if they're kind of hemming and hawing, then you're doing it no matter what, pretty much. So yeah, you're right. It's a very difficult situation. But the physicians, if they can show you a physician order of life-sustaining treatment, you're done. Is that right?
Yeah.
Then we're not doing
And
it.
in all honesty, I mean, it was clear to us, the DNR, like what they wanted. It was more the family pressuring for other things. And I'm just guessing the conversations didn't happen,
Yes.
or they couldn't, they didn't expect it as soon as it happened, and so they couldn't accept that the do not resuscitate really meant do not resuscitate. That's where the strength of the healthcare agent being able to advocate for your wishes is really important.
I had a situation in a hospital once where a patient called,
And the doctor had previously said, I want you to talk about code status with this patient. I'm concerned about what's happening. And I don't think we're going to do much to get forward. Stop breathing. Person coded, their partner was there with them. The partner said, why don't we try a little bit? And I was going to the floor and they said, well, maybe not. Well, maybe. I said, I'm sorry, I gotta go down the code. I need to call the code. And then the code was called pretty quickly, stopped pretty quickly, because then the partner said, no, stop all this, I just want to walk over here. That's what
My mother signed that paper, and I was with her when she died, and that was my.
oh, sorry, my battery died. Oh, that's right. That's what happens when you.
Do not hesitate. She's pretty skittish.
it's got something at least. Okay, thank you. Okay, and you were saying?
Yeah, my mom signed the paper when she was
Okay, yes. Wonderful, wonderful. What a blessed thing. You know, that's one of the things about if we're doing all this treatment, you know, that stuff doesn't happen. They're pounding on your chest instead of having that happen. Yes. It's wonderful stuff. It's wonderful, you know. Yeah. And you'll never forget those experiences, and they will impact you for the rest of your life. Haven't had that experience. That's wonderful.
Say, you know, it's been brought to our attention that the camera that you're on live streaming doesn't view anything farther back than here. So.
Okay, I gotta go. Thank you very much.
Dawned on me.
Good deal. Okay, good. Other comments about that? Other questions about that? So, and I do have a POL pulse form here if anybody wants to see what they look like. And what you have to do for a pulse form is you have to go to your primary physician and you have to sign what you want done or not done in life-threatening situations. So that's how to fill out a pulse form. And but your physician will help you fill that out, and then he or she has to sign. Questions about any of that? The last thing is, in event I'm pregnant, I don't think any of you are pregnant here or planning to get pregnant, so I don't think we have to worry about that. So that's the first part of it. That's a big part of this whole thing, and that is naming your healthcare agent. Before you name a healthcare agent, be sure to talk to them about the fact that you're naming them as a healthcare agent. And be sure that in your heart you feel very confident that they can fulfill your wishes. I have seen situations in my work where healthcare agents were saying, well, Dad said he didn't want a tube feeding, but he wasn't envisioning this situation. I'm sure he wants a tube feeding now, so we're going to put a tube feeding in. And that's really not good when they're starting to say, well, he doesn't really understand this stuff, so I'm going to do it for him. Figure it out. And that puts the healthcare provider was in a very difficult situation. And a lot of times what happens in those situations, unfortunately, even though it shouldn't, because this is a legal document, the healthcare provider can be somewhat frightened by a very strong-willed family member and say they're the ones that are going to sue me, not the person whose healthcare I'm providing. So that's make sure you trust your healthcare agent to make decisions based upon what you're saying in here. Okay. Any other questions? We'll go to part 2, healthcare instructions. A couple of really important questions are going to be asked here. My choices and preferences for healthcare are as follows. I ask my healthcare agent to communicate these choices and my healthcare team to honor them if I cannot communicate or make my own choices. I've initialed the box below for the option I prefer for each situation. And in all this whole document, you don't even have to appoint a healthcare agent in this document. If you just want to put down a few healthcare instructions in the document without putting an agent, you do not have to fill this whole document out. Whatever you want to put in this document, whatever you want to fill out, you can. But it's much better if you declare an agent, put down your wishes, because then the more thorough this document is, the better it is for making good decisions for you. So, cardiopulmonary resuscitation, CPR. How many of you know what CPR is, or have seen it on TV, or kind of have an understanding? You pound hard on the chest, and you don't, on TV they don't go like that. They go, I mean, you got to push your chest and your rib cage hard enough so the heart is pushed on and pushes blood up to the brain. Ribs can break. Things can happen in that situation. It's a very difficult procedure. The other thing that is to do mouth-to-mouth resuscitation, or if you're in a hospital setting, they got machines that will do that for you. Get a tube put down into your lungs to breathe for you. That's what CPR is. It's getting your heart, it's pushing on your heart hard enough to bring blood to the brain when the heart is no longer pumping, and it's pushing air into your lungs when the lungs are no longer breathing on their own. And so, a decision for the present. This decision refers to a treatment choice I'm making today based on my current health. And then it talks about item 3, a decision for the future, and that'll be in the next section. And this talks about what CPR is. One of the things about CPR that you want to know is that the more health conditions, chronic health conditions you are, the worse health you're in. Usually makes it less likely that you're going to be resuscitated and go back to a full life after resuscitation. I don't know what the statistics are exactly, but I think it's pretty close to half the people that survive a cardiopulmonary arrest, so their heart or lungs stop breathing and they're resuscitated. Probably, I think it might be half or so, or less than half, that ever get out of a nursing home again. Most of them spend the rest of their life in healthcare institutions. Not always, and there are situations where, like a drowning victim, if you can resuscitate a drowning victim, many times they do really well. But if you're 75 years old and you've got some chronic health issues, the prognosis is not as good. It's not like you see on TV where they do a little pushing on the chest and pretty soon they're all fine and they're talking to you again and everything is good. But I don't want to give you a too negative picture either. CPR has saved many people's lives, and I'm sure as a first responder, you have seen that happen. You do save a lot of people's lives with CPR. It's great
I
stuff.
had a professor once in my master's class who was saved by CPR, and first responders at his house, and then went on to, tell us about it, which is pretty.
That's really neat. That's neat, and I'm sure many people who do that have got great stories like that. So it's wonderful stuff, and we try to make it better and better all the time, but it doesn't do miracles sometimes, let's put it that way.
I have a question.
Yes.
Is CPR different from, say, artificial resuscitation?
Okay.
For instance, a drowning victim, is that?
It would be pretty much the same. It's a little bit different with the drowning victim in that you're going to first of all try to get that fluid out of their lungs because it's full of water in the lungs. You got to get that out before you can get those lungs to start want to breathe again. But it's pretty much the same thing. It's pretty much. And if if they're got a drowning victim and you get some of the water out of their lungs and their heart isn't beating, you're pushing on their chest to get their heart to push blood up to the brain. And you're also giving them artificial mouth-to-mouth resuscitation as well if they're not breathing. So it's pretty much, it's basically the same thing, but in certain situations you do different things. Because a drowning victim, if the lungs are filled with water, no matter, it's not going to work to try and get those lungs to start breathing again if they can't push the water out. You got to get the water out sometimes. So. Is that a good explanation of that? The difference between the different CPR ones? Okay. So you've had more experience. I called a lot of codes. I really never did CPR, to be honest with you. I had to call codes in the hospital at times. But there are people in the hospital. People get there really fast. You get the patient positioned, and they're there, and they start doing it. And so a lot of times I didn't have to start a lot of times. So the first option that you can do is you can say, I want CPR attempted and my heart or breathing stops. And it's just a clear statement. I think my health is good enough right now. If I stop breathing or my heart stops beating, please do resuscitation on me no matter what. The second one is, I want CPR attempted if my heart or breathing stops based on my current state of health. However, in the future, my health has changed. For example, I have an incurable illness or not much chance of survival if my heart or breathing stops. Then have my healthcare agent talk to the physician about this. And this one here is an interesting thing. Basically, what you're saying, the situation which this comes to play in is not the situation where you drop down in the shopping center and you can't breathe and your heart stops beating. That's not what this is going to talk about. Then you're going to do CPR. If you check this box, you would have CPR done on you. This box here is more what happens in the hospital when your health is not so good. You haven't coded your breathing and your heart's beating, but it looks like you might not live very long. And at that point, what happens here, when you check this box, what you're saying is, yeah, I want CPR attempted, but let's be reasonable. If I've got incurable cancer and things aren't looking good in the hospital, maybe we should make me a no resuscitation person in the hospital or in the nursing home or wherever I'm at in an institution. And that's where this comes into play. This one just kind of confirms to your healthcare agent, let's be reasonable with this stuff and let's not do things that don't make any sense in terms of CPR. And the third one says, I do not want CPR attempted if my heart or breathing stops. I want to allow a natural death. Understand, if I choose this option, I should see my healthcare provider about writing a do not resuscitate order. And again, with that, if you're not in an institution like a nursing home, you probably also should go to your physician and have a pulse written for yourself so that you've got that at home in case you need it at home. So those three options, do they make sense to you in terms of what the options are? Any questions about what CPR is or what those options mean? When my wife and I filled it out, my wife said, I don't think I want CPR attempted. And my wife's in good health. She's in as good health as I am, I think. And, I said, Kathy, my wife's name is Kathy, she's in the next room. I said, Kathy, if I woke up one morning and you kind of collapsed in a heap and you weren't breathing, I'd have a really hard time just kind of watching you, just kind of not trying to do anything for you. Can you think about this decision that you're putting into this document here right now? Because I'm your healthcare agent, and I wouldn't feel good doing that if you tell me you don't want that done. And she thought about it. She decided to check the middle box in the end, which is what both of us checked. And the middle box is just, yeah, we want it attempted, but let's not be crazy with this. Let's not do it in situations where it makes no sense, where our health has changed a lot from where it is right now. And the other thing about CPR is, if your heart or breathing stops, it stops for a reason. There's something very serious going on. And so to restore you to normal health after whatever it was that caused that to happen is difficult for healthcare providers. It's not easy to make that happen. Questions, thoughts? All of you kind of have a sense of what you might want to check in that box? It's a very important decision. That's one of the most important decisions on this document. And then it says on page 4, treatment choice is my health condition. My treatment choices for my specific health conditions are written here. And with any treatment choice, I understand I will continue to receive pain and comfort medicine as well as food and liquids by mouth if I'm able to swallow. So whenever you write, writing like I don't want to be resuscitated does not mean that, well, if you're really sick, we're not going to do anything. We're not going to give you pain medicine, or we're not going to give you food and water or whatever. It just means we're not going to do these life-extending procedures for you at that time. And the other thing with this one, it gives you a chance to write down. Like I've talked to people who, you know, my mom or my dad had a stroke and they got put on tube feedings after the stroke, and I hated it. And so don't ever put a tube feeding in me. This is a place where you can write things like that. Or so-and-so was on dialysis and they hated dialysis, and I would never want to be put through dialysis. Write it down in a place like this. That's where you can write those kind of things down. Just make sure. And some people come to their healthcare directive, they want to write it just because I don't ever want dialysis. And so that's the thing they want to say the most. Make sure it gets written on here somewhere if that's what you're thinking or feeling, or if you've seen horrible situations where you thought things weren't done as they should be. And I've also had people come to me at a healthcare directive class like this and say, you know, my mom at the end of her life, she had a urinary tract infection and she was a no-code blue, and they didn't treat her with antibiotics, and I think they should have. I think she might have come out of it. I think they should have treated her. And so sometimes people come there thinking, I want to make sure that certain treatments are done for my loved ones if they're really sick or towards the end of their life. So it can go either way with that. Questions, concerns about that? Next one. This one here is a hard one to imagine. It says, treatments to prolong my life, a decision for the future. And when you figure out this, you got to listen very closely to what this says. If I can no longer make decisions for myself, so either I'm very confused and I'm not of clear mind, so I can't make decisions for myself, or I'm unresponsive and I can't speak to you because I'm unresponsive, I'm out of it, I'm in a coma. And my healthcare team and agent believe I will not recover the ability to know who I am. So if I'm confused but awake, they think that I've got such bad Alzheimer's or dementia that I'm never again going to know who I am. If I was in that situation, either totally unresponsive or never and not expected to recover my consciousness, or so confused that I will never know who I am again. And if you're going to relate to me, I don't know who you are, and I don't know who I am. Then what would I like done? And there's two choices here. The first choice, and it says with either choice you're going to get pain and comfort medications as well as food and liquids by mouth if you can take that, if you can swallow. Do you want everything that's going to extend your life stopped and withheld? So if I'm in that situation, don't try to extend my life. That's not living for me, to live in a coma or to live where I don't know who I am and I'm not expected to ever recover the ability to know who I am. That's not, I see no value in that life, and I would like that. It doesn't mean you give me medicine to kill me. It means don't try to extend my life at that time. And that's what this document is saying. It doesn't say doctors give them an extra dose of this or that so that they die, but it means don't try to make me live any longer than what I can live on my own at that point. And so it does withhold all these treatments like IV fluids and tube feedings and breathing machines and CPR and antibiotics and stuff like that. Or the second one is, I'd like my all treatments recommended by my healthcare team, and that would be where the healthcare team would say, maybe this could be good for you. And that includes, not limited, tube feedings, IV fluids, respirator, CPR, antibiotics. The first one says, I can't imagine that the healthcare team would have anything to offer me. Please don't try to extend my life. And the second one is, my healthcare team thinks that something might be good for me. We can talk about it with the healthcare team and make a decision in conjunction with the healthcare team. Those two choices make sense to you? Yes.
You said earlier that this second one, all treatments recommended, can you limit that for a month? You know, give me antibiotics for a month. If it's not cleared up, then discontinue that.
You certainly can write those kind of things in. Give it a chance. Try tube feedings for a month. Try antibiotics or try some of this stuff for a month, but don't let it go beyond a month. Or say,
what is a good parameter? I mean, if
That's a really good question. It's really hard to know. With situations like strokes, usually the physicians will know quite a bit by the end of a month or two. That things aren't coming back and that not much is going to happen, not much is going to change anymore. But sometimes it could be 3 or 4, and then you get these miracle stories of 5 years, But so there is no magic answer to that question, unfortunately. But if you kind of, it's a matter of saying, I can't imagine that I want to be lying here in public for a year waiting on this moment. So maybe a month, Or I can't imagine myself not able to swallow for a year. So I don't know if that answers your
It
question.
does.
There's
There's
no
no,
magic answer to it,
yeah.
unfortunately. And sometimes in my cancer nursing, I would see people that were kind of waiting for a miracle. And so our treatment said, this person has totally curable cancer. We're not, this person's probably not going to live very long at all. The family's praying and hoping for a miracle. And so they're trying to say, well, let's keep doing this and this and this so we get a miracle a chance to happen. My thinking is, if you're looking for a miracle, then don't look to your healthcare providers to provide that miracle. Somebody else is going to provide that miracle for you. That was always my thinking. Because I can't do those miracles other than what my science tells me. That was kind of my thought in those situations. But at the same time, as a healthcare provider, you never want to keep hope away from too long. Trying to help people have some hope. I just want to have a monthly based on even if they have one. You don't ever want to just take away all their hope at the same time. You don't want to give them false hope. Say, yeah, well, we can maybe live for another year. No, I don't think medically I can't do that. A miracle happens, a miracle happens. And I saw miracles, I've seen it. So on patient we sent home to die because we took his acute leukemia in remission and we sent him home to die. And he did not. He lived for a year. And we had no explanation why he lived. Now the answer is sometimes miracle-like things happen. One other thing I should mention, does that make sense, those 2 options? Do they make sense to you? Any questions about that? At the bottom of the directive, it says, this is a directive of, and it says, check your battery again. Is that roll again? Very good. How long the battery's been up there? That's good.
You might want to move the microphone up a little closer.
Okay. We'll do that. Thank you. Does that look better?
So I think these backup batteries have been sitting up there for too long.
Oh, okay. I'm sorry. Can I yell? Will that help?
You're good for now.
Okay. Very good. Okay. Can you hear me? Okay. Okay. Any questions about treatments? Oh, I was talking about the bottom of the page where it says on the bottom of each page, it says this is the directive of, and they want you to print your name or write your name and also the date completed. Don't fill that part out until you're getting it signed because you want the date completed to be the date that this was made legal by being witnessed. So you don't want to put today's date on these pages. You want to put the date that you're able to have it witnessed. And we'll talk a little bit about witnessing and making it legal in a minute. Okay? So,
Can I add just one thing about
Yeah.
this section up here?
yes.
So where it talks about treatment choices, my health condition. So I named on a couple different healthcare directives, and a few people, when they drafted their language there, have talked about their quality of life. I'm just going to encourage you that if that's something that is a factor for you, that your healthcare directive person know what that means for you. Because the people who I am named on their healthcare directive have very different definitions. And if we didn't have those conversations, I might not make the best decisions if I was put in that place because it's a spectrum for the 3 of them. And they don't define that at all the same. So if you find yourself writing around things that might be different for other people, to at least
Absolutely.
articulated that, you know, you don't have enough pages or whatever. Because I knew the people well enough to be able to say, well, what does that mean to you? Because if I asked so-and-so this, for them it means this. Oh, it doesn't mean that to me. Okay, so what does it mean to you? So just food for thought.
Thank you, thank you. And there are a few other places where we got open spaces where it says what would make life not worth living and what makes life worth living to me. And those kind of things are important. I mean, you don't have to fill them out, but boy, they make a difference. And it helps them, your healthcare agent, to interpret what makes a difference to you at the end of life and what would make it life worth living for you. Very good. Thank you so much, Mary. You're a real resource here. Thank you. You can do this class. We'll go to page 5. And on the first page, it says organ donation. One thing I want to caution you about, if on your driver's license, if you have designated yourself as an organ donor on your driver's license, that driver's license is a legal document. Once you get this signed and witnessed, this is also a legal document. Do not write on your driver's license donor, and on this, I don't want to donate, because that would be a real complicated situation for your healthcare agent. They would have two different documents that contradict themselves. So if you are a donor on your driver's license, then please let them know on here that you want to be a donor, or else if you don't want to be a donor, change it on your driver's license, because they're both legal documents. Organ donation, I want to donate my eyes, tissues, and or organs, if able. My healthcare agent, according to municipal law, may start and continue treatments or interventions needed to maintain my organs, tissues, and eyes until donation has been completed. So you want to, or I do not want to, or my healthcare agent can decide. Those are the 3 choices here. Only initial one of those boxes. On the cancer unit, we did not have breathing machines and things to keep people alive. And so when a person died on the cancer unit, we could not donate major organs off the cancer unit, because once their heart and their lungs stop, the major organs are no longer any good for donation. So, but in an ICU where you've got a person on a breathing machine, and if you were in a serious car accident and they do some brain tests and they determine that there's no brain function going on the higher levels of your brain, and they declare that you are brain dead, but your heart and your lungs are still functioning for you, at that point is when your loved ones, your healthcare agent, will have the opportunity to talk to the donor agency and decide if you want to donate things like your kidneys and your heart and your lungs and your liver to other people that save their life.
Is there an age range on that? Most of us are getting...
I'll tell you one thing. When I started working in cancer nursing 35 years ago about, if you were over 75 and we called the donor agency about eyes or the tissue like the bone and cartilage and things that people could, and connective tissue that they could donate after their lungs and heart had stopped. Usually if you said they were over 75, the conversation ended and they said they're not a donor. Now, you can say you're 92 and they'll say, what did the person die from? What was the cause of death? It's unbelievable what they can salvage, and it's also unbelievable how much need there is for it. For example, I had a tooth right here. It's an implanted tooth right now. The root got reabsorbed by my body, and the root was getting destroyed, and I needed to pull the tooth out and to get put a thing in. When they put a post in to hold this implant in, they do a bone graft. So I got somebody else's bone up in the middle of my top gum up here that's helping to hold the post of that tooth in. Bone and cartilage and connective tissue and all that kind of stuff is really needed. And eyes, corneas of the eyes. A person who's died and doesn't have a heartbeat and doesn't have lungs can still donate the cornea of their eyes. And it restores sight to somebody. It restores sight. And so there's unbelievable needs for it. And the needs for major organs are huge too. What happens in the ICU with the major organs, what it says here is that you can make interventions to maintain your organs, tissues, and eyes. It means that sometimes until they could find a good match for these major organs for someone who's brain dead, they're going to keep those lungs and heart going maybe for 12 hours or 24 hours. It's not like 2 weeks or anything like that, but until they find a match, they want to keep those organs viable so that they can be donated or transplanted to another person. So it's a pitch for organ donation, but again, it's your choice what you would feel comfortable about with this. Questions about organ donation?
Yeah.
Yes.
If you donate your eyes, how much time before or after death have you got
Okay.
to remove them?
Okay. What happened when we had people that wanted to donate their eyes on the cancer unit? Usually we put ice packs on their eyes and we sent them to the funeral home, and the funeral home took care of it from there. It wasn't like it had to be done in the next 20 minutes or half hour or anything like that. They did at the funeral home probably a day later, I think sometimes, at least hours later when it was done. But I know they frequently, yeah, what?
My brother died of a heart attack and was found in a hallway, was taken to the hospital, ended up at the medical examiner's office, and we were contacted after that about eye donation. And it had been, by the time we heard from the donation place, probably 24 hours. EME had done whatever they did because of maybe something on his driver's license, I'm not sure. But it was definitely not instantaneous that goes, that
Can be done, and again, used to be even you're over 75, well, no donation accepted. Now, if you've got good corneas, they will take them and they'll see if they can find someone to give them to. And it's a gift of sight. I mean, it's literally someone who wasn't able to see before can now see. I mean, can you imagine being unable to see and then all of a sudden you can see? Or being seeing so poorly that you couldn't read and all of a sudden you can read again and watch TV again and stuff like that. I mean, it's amazing. The gifts of donation are spectacular gifts that we give to other people. So, those are the three choices. Again, make sure it fits with what you have on your driver's license as well. Autopsy. You got two choices on autopsy. My healthcare agent may request an autopsy if the autopsy can help others understand the cause of my death or help with future healthcare decisions, or I do not want an autopsy unless required by law. Autopsies are required by law in certain situations. For example, my oldest sister, I had mental illness and I found her dead in her home and she lived alone. When that death happened, the coroner had to be consulted to make sure there was no foul play because she had been alone in her home when she died. In that case, they do whatever they need to do for their autopsy and there's no charge to the family or the estate. It's that. If a person comes to the hospital and dies within 24 hours of being hospitalized, the coroner has to be consulted to make sure that that the hospital did the right kind of things. Even if the person was end-stage cancer and you knew they were going to die in several hours when they came to the hospital, the coroner still had to be consulted just to make sure there was no foul play had been done or no mistakes had been made at the hospital. In those situations, whatever the coroner does and whatever charges there are, it goes to the county or goes to the state, and so they're not on the personal. If, however, you have a genetic disorder, or you wondered if you died of a genetic disorder, and you want to know whether or not your family might have this genetic disorder because you might have it, and so you want to do an autopsy for the sake of that, then you do what's called a voluntary autopsy. And in a voluntary autopsy, the estate of the person who's died is responsible for the cost of the autopsy. Autopsies are usually not very inexpensive. They are usually pretty expensive. It doesn't run into hundreds of dollars. It runs into several $1,000s usually for a major autopsy. So you can either say, I don't want it unless I have to have it, or let my healthcare agent decide. But many people do not want it done just because of the cost. So that's. Yeah, that's right. You have nothing to say about it. I had nothing to say about whether or not my sister had an autopsy done. It's just done. So, okay. Any questions about autopsies? We're coming to the end of this document. We've got a few minutes left here. And this one is my hopes and wishes. It's optional, but it's a wonderful thing, and some of the best healthcare directives I've ever read have got this page filled out, and it's wonderful to listen to. The things that make my life most worth living to me are, can you imagine if you put in there, the things that make life most worth living to me are my children and my grandchildren? Can you imagine what your children and your grandchildren are going to feel like when they read that? They're going to feel pretty good, You can really, and many people, when they say that, they're honest. This is what makes my life worth living to me. Or maybe my life worth living because I can go fishing, or go fishing with my family, or go up to our cabin with the family, or whatever. But it will give you an indication of what's important to you. And then when the person says, you know, we got to make a decision here whether or not to extend her life or his life, and you know, he's never going to go fishing up in that cabin, or he's never going to know who his children are or who his grandchildren are again, then maybe you say, well, you know, life doesn't sound like it's too much worth living to him, and that's the condition he's in right now, or she's in right now. Second one, my beliefs about when life would be no longer worth living. If I couldn't get out of bed by myself, if I couldn't feed myself, I mean, there could be a lot of different things you could put on that some people would say. And that, again, helps your healthcare agent to understand, one, is it that you don't want life-prolonging treatment anymore? One, is it that just let me die if that's what's happening right now, and I don't try to extend my life. My thoughts about specific medical treatments. Again, if you don't want dialysis, or you don't want tube feedings, or whatever, this is a place to put that kind of stuff. Or if you do want something. Dialysis was great for my uncle, and I'd love to have it for me if I need it. Just do it. And then my thoughts and feelings about how and where I'd like to die. Very important section. One of the things that I caution people is it's not a really good idea to put never or ever in that category. You say, don't ever let me die in a nursing home. There are situations where it's going to be really difficult for any of your family members to be able to take care of you 24/7 if you need 24/7 care. And you could put a lot of guilt on your family members if they say, I just can't do it. I got to put mom or dad in the nursing home. So, but I would like to die at home if possible. Or some people say, I would like to die in the hospital if possible because I don't want to be a burden to my family, or I'd like to die in a nursing home or whatever. So if there's thoughts and feelings that you have about that, that's really helpful to your family members to know what you would like if it's possible to have it happen. If I'm nearing my death, I want my loved ones to know what I would appreciate, that I would appreciate the following for comfort or support: rituals, prayer, music. My wife is a church musician. She plays organ, piano, mandolin. She loves classical music. She said, I want classical music played if I'm dying. I didn't know that about her until we wrote our healthcare directive. I said, okay, I think we could do that if that ever happens. I am one of these people that's just kind of, I like peace and quiet. My thought was, be with me if you can. Just hold my hand if you can. And that's the way I'd like to die. My loved ones would hold my hand. Religious affiliation, I'm a member of the certain faith, and I'm a member of the Lutheran faith, a member of Bethesda Lutheran Faith Community in Malmo. Contact them about funeral arrangements. That would tell them where to go with that. Other wishes and instructions. I have pre-planned my funeral through such and such funeral home. Contact them and everything will be taken care of. Or I don't have any pre-planned funeral. Check with this funeral home and work with them about that. So again, you don't have to fill out any of this, but boy, some of this information is really, really, really valuable to know, to try to help make your healthcare agent know what you would want in certain situations. Questions about that? Questions? Okay. Legal authority. When you fill out your healthcare directive, don't sign this. Don't sign that and then bring it in and say, now, can you witness this for me? As a witness, the only thing, when I witness these, and you can do it, you can make this legal in two different ways. You can find two witnesses that are not going to inherit from you in any way whatsoever or have no association with you. Like I could be a witness to any one of your healthcare directives. Find two people to witness it, but in their presence, you have to sign your name and date this. And then they say, and you got to show them their driver's license. You got to show an ID or whatever. But the only thing I'm saying is, so-and-so who wrote their name there is so-and-so. And I looked at her driver's license, and she's the person that says she signed it here. That's the only thing I'm doing when I witness this. But don't sign it ahead of time. And you can also take it to notary public, most of your banks and sometimes hospital. She's a notary, so you've got everything all set up. So, but basically, all the notary does too is you're just saying this is who the person who says they signed it. That's the one who signed it. They're who they said they are. That's the only thing there. But Wait with that and wait with dating on the bottom of these pages until you're ready to have it signed and witnessed and made legal. Okay. Last things, things that you should do after you complete this. First of all, destroy any previous ones you've made. And then tell your primary and alternate healthcare agents, make sure they're able to do this important job. Give them a copy of your healthcare directive. Talk to the rest of your family members and close friends. Might be involved if you had a serious injury, making sure they know who your healthcare agent is and what your wishes are. Give a copy to your doctor and other healthcare providers and make sure they understand and will follow your wishes. And most healthcare systems now, I don't know what the major healthcare system is here in Malmo, but if you get it to one part of that healthcare system, like in St. Cloud, Centricare is our healthcare system. If you get it to one Centricare facility, every clinic and every hospital that's connected with Centricare will have copies of it because the charts are all connected. So find out who needs, and if you have, like for us in St. Cloud, if we also get care at Mayo Clinic or at the University of Minnesota or something like that, or the Veterans Hospital in St. Cloud, then we need to get a copy to them as well. Keep a copy of your healthcare directive where it can easily be found. Don't put it in your safe deposit box. Put it in a place somewhere where your family knows where it's at so they can locate it. And always keep the original. Do not give the original away. Make copies for other people, but always keep your original. And if you're going to a new healthcare facility, bring the healthcare directive with you so that they know what it is. And then it says every decade you should be looking. When you start a new decade, I just turned 70, so I should have looked at my thing. When you experience the death of a loved one, when you experience a divorce or other major change, when you're diagnosed with a new serious health condition, or when you have a significant decline in your health, the 5 Ds, then you should look at your healthcare directive and make sure it still is in touch with what you would want at that point. So and then you can write down who you made copies to. This is a page for your own personal. You don't have to do this, but it's something that you can do in that way. Oh, I've got some physician orders for life-sustaining treatment, if anybody would like to see what that looks like. Any questions before we close? Look at that, we got that done in 2 minutes late. Not too bad. Thank you all. Thank you. Thank you.
Thank you, everyone. And if you do need a notary, obviously no pressure, but don't hesitate to reach out to me, whether that's asking Mary for my email or a phone number. I'm happy to meet you here and do what needs to be done, or else 2 witnesses that aren't named in your document or listed.
I just want to say if anyone wants, that's listening, or wants help filling one out, you or me
Yep.
will help you.
Yep. We'll meet you up here. We'll talk to you by phone. We can do it virtually, whatever works for you. If you want to talk through different scenarios, yeah. Yeah. Thank you, Mr. Brummer.
Thank you. You guys got some great resources here. Thank you.
There is some soup in the fellowship hall for those that would like some lunch, and thank you for coming.
Thank you. Thank you all. I appreciate your listening, and it was a great time. Thank you, Mary. Good. Hopefully it made sense to me, what I was talking about. It was so nice to have you, because you have a whole different level of experience with first responders than I do. That was really neat. Yeah.